Hello everyone, my name is Sakshi and welcome back to my channel. I'm fourth year pharmd student and today we would be discussing the case study of ischemic stroke. And before jumping right into the case study, I would like to tell you guys that pharmd first year to pharmd third year notes are already available. So you can mail me at patelsakshi164@gmail.com for the same. Also, because this is the first case study that I'll be discussing, so if there is anything that you would like me to include, such as the standard pharmacotherapy or the management chart of any diseases, then let me know, or of the specific case study and the pathophysiology, if you want me to go in depth, or the diagnostic test, anything, that let me know in the comment section below. Also, if there is any specific case study of any specific disease that you would like me to discuss, then also let me know in the comment section below, because it is my fourth year, so I would like to say that I have pretty much loads of cases in my pocket. So let us now jump directly into the case study. A 60-year-old female patient, not a known case of any major illness, that is, she was not having any kind of diabetes mellitus, hypertension at that time, or any other cardiogenic disease. Presented with complaining of sudden onset of vomiting since afternoon and altered behavior. Then the relative took the patient to some private practitioner outside and recorded the blood pressure to 240/100 mmHg, which is very high. So MRI of the brain done, which was suggestive of multiple discrete acute area in both cerebral hemisphere, vermis and occipital lobe. On admission, the patient was conscious and oriented. Patient is managed in ICU with IV fluids, antibiotics, antacids, injection Lobat, that is labetalol, injection NTG, that is nitroglycerin. Patient relative wanted to discharge, so discharge against medical advice, that is DAMA, was given. So coming to doctor notes or progress notes, 60-year female, that is a geriatric female, no known comorbidities, presented with the complaints of sudden onset vomiting since 2 a.m. in the afternoon, altered behavior since then, consulted some practitioner outside, which recorded blood pressure was very high, 240/100 mmHg, no history of fever, cough, abdominal pain, no LOC or conversion. Now she was on examination, she was conscious and oriented. Pulse, BP, when she was okay, because she was given labetalol already and nitroglycerin, that's why her blood pressure came down to normal, which is 190/110 mmHg. Respiratory rate was normal, SpO2 normal, RS clear, CVS S1 S2 positive. So what this tells us is that there are three things. First, it is a geriatric patient. Second, she was having blood pressure very high, which was 240/100 mmHg, so we have to manage that. Now the third comes stroke. So what kind of stroke the patient might be having, because due to high blood pressure it could be hemorrhagic stroke or it could be ischemic stroke, right? But here we have another diagnostic tool, which was the MRI. So MRI of the brain, it was suggestive of discrete acute areas in both cerebral hemisphere. Now what this tells us is that discrete acute areas means there were white areas. Now white areas in the brain MRI, they are suggestive of ischemia, and if it is hypointensive or normal, so it is due to hemorrhage. Okay, so because there were white areas, it was suggestive of ischemic stroke. Next we have the lab test. So for the lab test, serum creatinine is normal, 0.78 milligram per deciliter. Then electrolyte levels, sodium, potassium, calcium were normal. Calcium is a little bit on lower side. Troponin is low. Now what troponin indicates is that if there were higher troponin levels, then it would have indicated us that the patient has suffered from any kind of cardiogenic disease. For example, she might have had an heart attack or atrial fibrillation, tachycardia, ventricardia, anything. But that is not the case here. So troponin levels are high, and there are two main causes of ischemic stroke. One is the carotid atherosclerosis and the second is cardiogenic embolism. So we can, I guess, very safely rule out cardiogenic embolism. Now coming on to differential count, neutrophils, lymphocytes, eosinophils, monocytes and basophils are normal. Histogram reveals that the total leukocyte count, RBC, is a little bit on lower side. Hemoglobin is okay, MCH, MCV, MCHC, everything is normal. RDW is normal, platelet count is okay. Coming to APTT, now APTT is 19 seconds, which is low. Normal it is 25 to 35 seconds. What APTT indicates is that if it is lower APTT, levels, then that means that the patient is having chances of embolus or thrombus formation in the blood. There are higher chances of having a thrombus formation in your blood if you are having lower APTT. APTT, it is activated partial thromboplastin time. So if that is lower, it means that you have higher chances of, if it is lower, then you have higher chances of thrombus formation, and here they are lower. Now if you are someone who is studying in third year, you might have come across this when you are studying anticoagulant. So in that, what we did is that if we are giving heparin, then we measure the APTT, because if APTT is higher, then it means that there are risk of bleeding. So that is why in heparin therapy, APTT is monitored. And for warfarin therapy, which is another very famous anticoagulant, INR, that is international normalized ratio, is monitored. So these two are very important. Anticoagulants are very important if you are third year pharmd student. It will come. Yeah, anticoagulant classification, write a short note on heparin, warfarin. That is like favorite question of most of the universities. Okay, enough about that. Coming on to the patient. So now we already know that the patient is elderly, she was having high blood pressure, so we have to maintain that, and it was likely an ischemic stroke. Likely nahi, pakka, it was an ischemic stroke, so we have to give treatment to that, for that case. Coming on to the pharmacotherapy, amlodipine, nitroglycerin, vitamin B1, 6, 12 was given, aspirin tablet was given, labetalol injection, pantoprazole injection, and atorvastatin was given. Coming on to why these medications were given. Now amlodipine, it is calcium channel blocker, so it will also help the patient to elevate or bring her calcium levels a little bit to normal level. She was having kind of normal level, but they were on decreased side, okay, lower end of the range. So it will help in that, and also to maintain the blood pressure. Nitroglycerin and aspirin. Nitroglycerin, it is first line therapy mainly for hypertension in such cases, because nitroglycerin, it really acts rapidly. Next comes vitamin B1 612 injection. Now this was a bit new to me, so I searched upon why it was given. I'm really sorry for the noise. Okay, so what happens is that if there are elevated homocysteine levels in our blood, then it leads to increased risk of dementia, heart disease, and stroke. So elevated homocysteine leads to dementia, heart disease, and stroke. Now we have to decrease homocysteine, right? So to decrease homocysteine, vitamin B6, 12 and 9 are given. So what vitamin B6, B12, B9 do is that they decrease or they break down homocysteine. Now also there is rule or formula, whatever, that 25% decrease in homocysteine leads to 10% decrease in stroke risk. Okay, I repeat, 25% decrease in homocysteine will lead to 10% decrease in stroke risk. That is the reason that vitamin B6, vitamin B12 and vitamin B9 injections were given. Alright. Okay. Now aspirin tablet. Now aspirin and labetalol, they are first line therapies for ischemic stroke. Aspirin, it is antiplatelet agent, and labetalol, it is again for high blood pressure. Pantoprazole, because aspirin, it is an NSAID which is given, that is why pantoprazole is also given, because NSAIDs increase the risk of peptic ulcer, and pantoprazole will help prevent peptic ulcer formation. Next comes atorvastatin. Now because we did not have cardiogenic embolism was ruled out. So the second main cause of ischemic stroke, it is carotid atherosclerosis, plaque formation, lipid plaque formation. So to lower down the lipid levels, atorvastatin was given. Sadly, I know that the lipid levels or the lipid profile test, it is not given. So let us assume that patient was having high lipid levels. Yeah, it is not given. So the patient was having high lipid levels. That is why atorvastatin is given. That is it for the case. So what we understood is that it was a geriatric patient. She was having complaints of vomiting since afternoon and altered behavior since then. So maybe she had a stroke before she had vomiting episode, and she was having altered behavior, and that was likely due to high blood pressure. Now how does high blood pressure cause stroke? So what happens is, due to high blood pressure, these are the walls of your arteries, okay. So due to high blood pressure, what happens is that due to continuous pressure, the walls of the arteries, they will get damaged. So due to damage, it can lead to ischemia or it can lead to hemorrhage. Now in this case, it led to ischemia. So yeah, that is it. And remember that if the area on MRI is white, it is ischemia. If it is hypointensive dark, it is normal or hemorrhages occurred. Okay, but just to confirm that, okay, area of area of hyperintensity will be depicted as white on MRI, which will be indicated as an area of hemorrhage, and dark area which will be hypointense or normal, it will be that in case of infarction. Okay, stroke is a new chapter for us. It will be taught to us a week after I shoot this video, so that is why I made my notes day before, 2 days before. And also I would like to share you some amazing facts or things that I got about stroke, about our amazing body. So first is normal cerebral blood flow. It averages 50 ml per 100 gram per minute. Okay, so cerebral blood flow, it is 50 ml of blood per 100 gram of tissue per minute. This is maintained over blood pressure of very wide blood pressure. It is about 50 to 150 mmHg by cerebral autoregulation process. So 50 ml per 100 gram per tissue over wide range of 50 to 150 mmHg by cerebral autoregulation process. How? By dilation and constriction of cerebral blood vessels in response to changes in blood pressure. So if the blood pressure is towards the lower end of the range, that is if it is 50, 40, then what will happen? If it is 50, 60, 70, then what will happen is that the blood vessels will constrict so that the blood pressure will increase. And if it is towards the higher end of the range, that is if it is 150 mmHg, 140 mmHg, etc., then the blood vessels will dilate. One important thing is that for cerebral autoregulation to work, the blood vessels should have elasticity, right? And as I said earlier, that due to hypertension, the blood vessels, they lose their elasticity. So, and also due to atherosclerosis, this process gets impaired by atherosclerosis and high blood pressure, and acute injuries such as stroke can happen. Okay, because obviously the cerebral blood vessels, they won't be able to supply blood to the brain. Coming to another point, 20 ml cerebral blood flow below 20 ml per 100 gram per minute leads to ischemia, and below 12 ml per 100 gram of tissue per minute leads to infarction. I repeat, cerebral blood flow below 20 ml per 100 gram of tissue per minute, it would lead to ischemia, and below 20 sorry, below 12 ml per 100 gram per minute, it will lead to infarction. Now, how is this significant? Because ischemia is reversible, infarction is not reversible. Infarction will lead to irreversible damage to brain, which leads us to another new term, which is penumbra. Now what penumbra is that? If this is a brain tissue, okay, very nice brain tissue, so this is the infarct core. Here there is no blood flow, or there is decreased blood flow below 12 ml per 100 gram per minute. Now this area, if it has retained its membrane integrity, then this area, it is known as penumbra. This is our infarct zone, which is having blood pressure less than 12 ml per 100 gram of tissue per minute. So this is the infarct core, and the surrounding tissue which has maintained its integrity, it is penumbra. So that is it. I really hope that you liked the facts. I really love the fact of maintenance of blood pressure over 50 to 150 mmHg, and yeah, knowing such facts and stuff like that, it really ignites your, what do I say, enthusiasm and curiosity to learn more, and it puts me in awe of our amazing body and makes me want to learn more. So I really hope that it helped you and you really liked my case presentation or case study discussion. If there is anything that you would like me to include or stuff like that, then let me know in the comment section below. This was the first case study discussion. Hopefully we'll have lot many, and also because I'm fourth year pharmd student, I do have lot many cases to discuss with myself already. So in case there is any particular case study that you would like me to discuss of any particular disease, then let me know in the comment section, or as many of you have asked me, you can mail me your case and I'll discuss them on my YouTube channel. And coming to YouTube channel, please don't forget to subscribe to my channel and share my videos as much as you can, because we really need some more watch hours. So I really hope that you would help me in that. And Also, a very happy new year to all the Gujaratis. Goodbye and keep watching my channel.